Bismillah ar-Rahman ar-Rahim. It's my pleasure today to share in this condensed course regarding COVID-19 patient. I am Dr. Osama Sobh, Chief of ICU in Kungi Saud Hospital. Our title today is regarding non-ventilatory intervention. My objective to go and cover through two subjects: prone position in COVID-19 patient and cytokine storm. As we know, in 2019, new virus started in the China. New coronavirus strain, and it's called COVID-19. This virus rapidly spread over all world country with high increase of mortality and become a great challenge for healthcare staff. It caused a pneumonia that was identified by fever, dyspnea, acute respiratory symptom, and named as COVID-19, as I mentioned. One of the serious complications with a very high mortality is the development of ARDS. Prone position can be used as adjunctive therapy to improve the ventilation in such patients. And as we know that prone position approved to decrease a mortality in ARDS patient years before, after approval, get a green light from Bruzova trial, and they found that it should be prescribed among the patient of COVID-19 patient, and of course the patient will be on the lung protective strategy, and patient will be deeply sedated or paralyzed by muscle relaxant. How it's work? How this prone position working? It work by improvement uh, of the lung condition by recruitment in the dorsal lung regions and expiratory lung volume, increasing the chest wall elasticity, decrease the alveolar shunt, and improving the tidal volume. However, correct selection of patient and applying proper treatment and protocol for prone position, this is the key of its effectiveness. How you select the proper time to start the prone position. Early start prone is much better than delaying and late state starting of prone. Another point very important, you must keep your unit. Your doctors and nurses must be familiar with dealing with the prone position, and you must have a clear protocol. In meta-analysis done by Minchi et al., it's expressed that a prone position can lead to drop in the rate of mortality among the patient of severe ARDS when you applied for at least 12 hours. And the usual protocol used in intensive care is 16-hour proning and 8-hour free. Interesting recent meta-analysis, multi-center observational study by Jorin et al. Shows that 13.7 only of patients of ARDS have been placed in prone position, and they're very interesting and surprising. And even in the patient with severe ARDS, the rate of using of this technique is 32.9. They mention in the study there is two main reasons for delaying use of prone position. Number one, based on the judgment of the physician, in most cases, the hypoxia in severe ARDS is not enough to justify the prone position. Usually, there is a hesitation of decision of physician or intensivist to early start of prone position. He will start late and will have a bad outcome, and most of ARDS patients will have hemodynamic instability. How you select this problem? By fixed protocol inside the unit for initiation of the prone position, by training of your nurse and doctors how they will prone the patient simply. And there is many teaching videos in YouTube which teach the nurses how to prone the patient very easily with a few number of nurses. So this is example of the protocol for prone position. In this protocol, we consider the proning of the patient very early, from 6 to 12 hour post intubation, or maybe more sooner if you feel that a patient he will get a benefit from prone. And the BF ratio must be less than 150. Increasing oxygen need, BF less than 150, and an optimal parameter of ventilator you are used, including high beep and high ventilatory setting, according to lung protective strategy. So you feel that your patient oxygenation not improve, so don't hesitate and go for early proning of your patient. There is some situation in which we have to exclude the prone, including pregnancy, increasing intracranial pressure more than 30, cerebral perfusion pressure less than 60, massive hemoptysis, tracheal surgery, sternotomy, facial trauma, cardiac pacing in the last 48 hours, unstable fracture spine, femur and pelvic fracture, patient also in severe hemodynamic, severe shock state, and on very high dose of vasoactive drug to keep and maintain the hemodynamic. And if the patient ECMO started, or the patient have frequently killer or ventricular arrhythmia. Special consideration, your patient must be deeply sedated, and it is preferable to be paralyzed to avoid any sudden movement and extubation, self-extubation of your patient. Consider placing of post-pyloric feeding tube and gastric tube to keep the stomach empty, and this technique not always used in all the center. And also you can adjust your ventilator setting, and you can utilize your ventilator COVID protocol. Adjustment of protocols of ventilation, it will be done during my colleague in other lecture. And is all inhale medication using of vasoactive drug, this is not contraindication of prone position. So what's the message for using of prone position? To get a benefit, you must start early, you must select your patient, avoid contra indication, put a fixed protocol, train your nurses and doctor to be easily practice for them. You have to stop bronze therapy if the following condition is there: pneumothorax, tube is out, patient in severe hemodynamic instability, if the patient oxygenation not improve, cardiac arrest, or you need to transport your patient. This is one very interesting study about prone position in spontaneously breathing non-intubated COVID patient. It's a pilot study by Xavier, and we are waiting for the result of this study. This point subject regarding Lebron, and we'll go to the very interesting subject. The second subject is the cytokine storm syndrome in COVID-19 patient. We mentioned that this COVID-19 or new coronavirus 2 is affecting a big number of patients with a high mortality. But there is some surprise that the patient who's affected started by mild to moderate symptom, and the patient continue to be stable for 5 to 7 days, and suddenly you'll find the patient deteriorated with the ARDS, multi-organ dysfunction, and death. And many of my colleagues ask me, why condition like this and suddenly the patient will be deteriorated? What is the reason? The reason is cytokine storm. It is considered one of the major cause of ARDS and multi-organ dysfunction. How it is happening? What is the mechanism? Many years before, when start MERS-CoV, it was known that several many pro-inflammatory cytokines include interleukin 6, 8, interleukin 1 beta, granulocyte stimulating factor, and many chemokines, and all this contribute with each other to creating an occurrence of ARDS. This research supports such point of view that following SARS-CoV coronavirus infection, the virus loading and dysregulation of cytokine and chemokine response cause an inflammatory cytokine storm. The inflammatory cytokine storm is accompanied by immunopathological change in the lung. What happened in COVID-19? And recently, COVID-19 have elevation of the level of T helper T cell cytokines, include interleukin 4 and interleukin 10, which inhibit the inflammatory response. The serum level of interleukin 2 and interleukin 6 in the patient of COVID-19 are positive correlate with the severity of the disease. That means it is higher in critically ill patient, severe patient more than the ordinary patient. And another study found that comparing with COVID-19, a patient from general ward and intensive care, if compared with each other, you will get that the level of granulocyte colon stimulating factor and the macrovage inflammatory protein 1A, T1 necrosis factor, and the other factor is much increased in ICU severely affected patient than the stable patient. So it is highly correlate with the disease severity. When COVID-19 started in the China, there was one paper released in the Lancet regarding severe type of coronavirus infection, and they found 37 of patients, 71.2% require mechanical ventilation, and 35%, 67.3 suffering from ARDS. The mortality was very high among the elder patient of ARDS, and the core pathological change is the pulmonary and interstitial tissue damage caused by non-specific inflammatory cell infiltration. And local excess release of cytokine is a decisive factor that induce pathological change. COVID-19, the cytokine storm is closely related to the progression of the ARDS. And as we mentioned, the serum level of you check of cytokine is in the patient with ARDS, and the degree is of this increasement is directly correlate or relate to the mortality rate. Also, it is a key factor to determining the clinical course of extrapulmonary multi-organ failure. This explains to us the sign of extrapulmonary organ as increasing liver enzyme and creatinine. It's seen in some COVID-19 patients without respiratory failure, suggesting that the inflammatory cytokine storm is the cause of damage to extrapulmonary tissue and organs. To summarize that, this new coronavirus or COVID-19 cause inflammatory cytokine storm, and this cytokine lead to ARDS and extrapulmonary organ failure, and it is important factor to cause exacerbation of deterioration and high mortality among severe affected patients. How we can stop that? You have to stop the cycle. How you stop the cycle? You have to early detect COVID-19 clinically by scoring a system and lab by the level of number of cytokines if it is available. Then you will use available option or recommended option to stop the circle. Unfortunately, a lot of study, big numbers, but all of them still we don't have a big randomized control trial for final approval, and we're still waiting for 7 or 10 or more of study to get the approval. Let us to go through the option which are available and demonstrate what we can use. In this strategy, we will start by the corticosteroid. Corticosteroid is a point of controversy since long time in use, and corticosteroid in patient of COVID-19 depend on time of administration and the dose of steroid which is needed. It's very important. And a too early administration of glucocorticoid inhibit the initiation of the body immune defense mechanism. This is known and made increase of the viral replication, viral load, and increasing the mortality. So which type of patient I will use? I will select it use in critically ill patient suffer from inflammatory cytokine storm. Inhibition of excessive inflammation through time administration of glucocorticoid in early stage of inflammatory cytokine storm effectively prevents the occurrence of ARDS. For patients of progressive deterioration of oxygenation, rapid image progress, excessive inflammatory response, the use of steroid for short time, 5 days, and a dose 1 to 2 milligram per kg per day. It should be noted that this is a recommended what we use in severely affected patient, small dose and for short time, 3 to 5 days to avoid complication and viral replication. And should be known that large dose of glucocorticoid may delay the clearance of coronavirus due to immunosuppression. The observational study and evidence suggests that corticosteroid use in patients, this is many years before and during MERS, that it was associated with no survival benefit and increasing the mortality. But recently, when we have COVID-19, some uncontrollable observational data from recent outbreak in China suggests that possible benefit of methylprednisolone treatment in COVID-19 patient with ARDS and some waiting result of randomized control clinical study evaluating the steroid and indirect evidence from the study sorry in patient with community acquired pneumonia, ARDS, and other viral infection has been used to inform us the proper treatment or proper decision in the COVID-19 patient. One of this study is observational single center study. It is retrospective, 200 patients including, and they develop ARDS. Steroid appear reducing the risk of the death among the patient used 46% comparing to the other group in which mortality was 61 0.8%. Another retrospective observational single center study. This is for few number, only 46 patients with confirmed severe COVID pneumonia progress to acute respiratory failure. Use of methylprednisolone associated with the improvement of the clinical symptom and is a day of staying in the hospital. Another open label multi-center randomized control study recently completing China and comparing the use of steroid in conjunction with the standard care when in the patient of COVID-19 with ARDS, and it shows there is a great improvement and decrease the mortality. A lot of trial going on in different country to evaluate, and this is the number of multiple uh, trial to initiate a methylprednisolone in this situation. Still, we are waiting for many results for many trial. Some observational studies suggest that patients with COVID-19 and ARDS treatment, as I mentioned, may be beneficial by methylprednisolone. We should interpret the result by caution because high potential bias during this study, and it is also small size. We still need big randomized control trial. But depending on expert opinion and in many protocol in different European countries, China, even in United States, they are using methylprednisolone, as we mentioned, in severe cases with ARDS in the dose 1 to 2 milligram per kg for a short time, 3 to 5 days, to avoid complication. We'll go to the intravenous immunoglobulin, very attractive option used during cytokine storm, but unfortunately the study is still we are waiting for confirmatory study to approve to be widely used. There's one paper in Lancet also from Wuhan, study to 99 patients. 27 of this patient was receiving immunoglobulin, and immunoglobulin therapy has a dual effect on the immune situation and immunomodulation. The efficacy data not available from clinical study till today, and COVID-19 clinical trial in China. This is a number of this open randomized trial initiate to evaluate the efficacy and the safety of the immunoglobulin in COVID-19 patient. Still, we don't have result. But what they use, dose from zero point 0.3 to zero point 0.5 gram per kg for 5 days. It's very attractive, and some centers are used, but still we are waiting of the result of randomized control trial. Another option, interleukin 1 family antagonist. During the cytokine storm, the most important family is interleukin 1 beta, and there is a study focused on the inhibition of interleukin 1 beta to reduce the cytokine. If attractions use some drug, one drug called an inquinina, and would antagonize the interleukin 1 beta and can use to treat the cytokine storm. There's currently no clinical experience to be applied in COVID-19. Still, we are waiting for more study to approve its use. We'll go to interleukin 6 antagonist. This is very important because it is widely used now, the tocilizumab. This is interleukin 6 antagonist. It suppresses the function of the immune system. It was used in rheumatoid arthritis, and it has therapeutic effect on infection-induced. This interleukin 6 is significantly increased in patients of COVID-19, and clinical study from China shows that tocilizumab is effective in treating a severe ill patient with extensive bilateral lung lesion and elevated interleukin 6. The first dose was from 4 to 8 milligram per kg. It is recommended dose 400 milligram at 100 ml normal saline, and the infusion time was 1 hour. Some patients with poor effect of first dose, they will need second dose after 12 hours. Many case report and about use of tocilizumab and observational study describing the use in COVID-19 from many different countries. Preliminary data from non-peer-reviewed single-arm observational study by Chinese trial involved 21 patients with COVID-19 infection. It showed rapid fever reduction, reduce of the oxygen subneed, and after receiving of tocilizumab dose of 400 milligrams. Another study, it is retrospective observational study in China also, 15 patients, but this patient they use combination this tocilizumab with methylprednisolone. Same study done by Italian group in it, and they are going to publish within coming few days. And there was compare between one group receive placebo and receive standard treatment, and second group standard treatment plus tocilizumab again, and third group received tocilizumab plus methylprednisolone. The effect was very good and mortality less in the third group. So different and controversial recommendation. China, they recommend to use in severely affected patient. NIH still not against waiting for a result of the study, and many recommendation and protocol they are used in a patient starting severe affection of COVID-19 with cytokine storm. A big study, randomized placebo-controlled trial by Roche, and conducted in 3 trial ways in collaboration with United States Health and Human Service and Biomedical Advance. The study will evaluate the efficacy of tocilizumab, and it will include good number of patients, 330 patients. We are waiting for result of this study, which started already in this month in April. We'll go to another option, tumor necrosis factor blocker, not being detected in the serum of the patient of SARS and not being suggested in the treatment of COVID-19. So it is still under study to be seen. It is till now, it is not recommended to be used in COVID-19 patient. The ulinistatin, it is very attractive factor and increase the level of anti-inflammatory factor. This make a balance between the pro and anti-inflammatory response in the human. and make interruption and stopping of the circle of cytokine storm. Unistatin is very attractive because not inhibit the immune function, not have side effect of steroid. So it is promising in treatment of COVID-19, but we need more study. Stem cell, important member of stem cell is the mesenchymal cells, not only have the potential of self-renewal and multi-differentiation, but it have a strong anti-inflammatory immune regulatory function. MSC can inhibit the abnormal activation of T lymphocyte and macrophage and use their differentiation into regulatory T cell. So it has a great effect and promising. It also inhibits the secretion of pro-inflammatory cytokines. So it's used to treatment of severe case of COVID-19 is very attractive, but it is still under clinical trial and we are still waiting for approval. What about blood purification treatment? There is adding to blood purification treatment, which we are used in our clinical practice to remove the inflammatory factor to some extent, including blood purification system, plasma exchange, adsorption, perfusion, blood plasma filtration. All can remove the inflammatory factor and block the cytokine storm and reduce the damage of the inflammatory response to the body. It can be used on severe and critical uh, but and also another technology like artificial liver technology. This was used in resistant cytokine storm H1, H7, and 9, and its application is promising in COVID-19 patient. Still all under clinical trial and study. Also remember that early renal replacement therapy, and usually in hemodynamically unstable, we are using CRRT. It is similar to a treatment principle of artificial liver function liver technology and seem to be an effective also measure to control the cytokine storm. Also, convalescent plasma still under study. There is some study, few patient, 5 critically ill patients studied in one study raised in gamma, and they found that its use neutralize the antibody, using of convalescent plasma, which contain neutralizing antibody, followed by improvement in some clinical status. There is also systemic review done for convalescent plasma transfusion to COVID-19 patients for 5 studies and show that convalescent plasma may decrease the mortality, increase neutralization of antibody, and beneficial effect on clinical symptom after administration of convalescent plasma. Including for that, convalescent plasma is a cheap and good method to treat the COVID-19 patient, but we need still well-designed large multi-center clinical trial should be conducted urgently to establish the efficacy. And finally, the strengthening of the vascular barrier, increased vascular permeability is a hallmark occur in the process of cytokine storm. Blocking that by factor is very important to stop the cycle, and this also is still under study, not approved till now. To give conclusion, first regarding prone position, we must have a good protocol, early initiation, early selection and detection of the patient and avoid contraindication. For cytokines storm, I must know the dangerous and I must know the timing of starting of cytokine storm. I must have a good scoring system, early detection, stop the circle. What we are using now is a small dose of methylprednisolone, 1 to 2 milligram per kg, 3 to 5 years, and immunomodulation by tocilizumab, and plus with or without immunoglobulin. Very other interesting, attractive option is still under study, and there is a big number of multi-center control trial going on. We are waiting for the result of our final protocol and decrease the mortality of such patient. Thank you very much. This is our team in intensive care. They are fighting in the war of the virus, and I hope the safety of all our people. Thank you very much. No. Mm.